Hello students, this is Dr. Ways and welcome to your lecture on the lumbosacral plexus. Remember back when we had the lecture on the pelvic floor and we talked about the sacral and coccygeal plexus, and that plexus went from L4 to the singular coccygeal nerve. Now here we're referring to specifically the lumbosacral plexus that goes from L1 to S4, and notice that there's some overlap between the lumbosacral plexus and the sacrococcygeal plexus in terms of L4 and L5 and then S1 through 4. So when we talked about the sacrococcygeal plexus, we talked about how it innervated items within the pelvic cavity. For the lumbosacral plexus, we're going to talk more specifically how those nerves coming from the L1, L2, L3 anterior rami, the lumbosacral trunk, innervate the lower limb. So we'll begin with the lumbar plexus, which is the upper division. In other words, if you're going down the spinal column, T12, L1, L2, L3, L4, S1, S2, and so on, the lumbar plexus sits physically superior to the sacral plexus, so we refer to it as the lumbar plexus or the upper division. And where this sits is, and here's the plexus part where nerves are sorting and recombining, it sits against the posterior wall of the abdomen, kind of within the psoas major muscle, which also receives innervation from this plexus. And as it says here, the lumbar plexus specifically will supply structures on the lateral, anterior, and medial sides of the thighs, not the posterior. So also notice on this that even though we call it the lumbar plexus, there's also contribution from the last thoracic nerve, T12. The two major nerves that we want to be concerned with coming out of the lumbar plexus would be the femoral nerve right here, and notice that the femoral nerve is made of contributions from L2, L3, as well as L4. And the second would be the obturator nerve, which is contributions again from L2, L3, and L4, although that nerve is much smaller than the femoral nerve. The femoral nerve is the biggest nerve coming out of the lumbar plexus. All right, so what I want you to notice on this slide is that the lumbar plexus, we'll see back here behind the psoas major muscle, the psoas muscles. We combine the psoas major and minor. And the femoral nerve comes out around the lateral side and moves down along in between the psoas muscle and the iliacus muscle. So it'll course down right here. And then the obturator nerve, as its name suggests, courses more medial to the psoas muscle and then heads toward, imagine it back here, the obturator foramen, where it's then going to split off into an anterior and a posterior division, or branch, if you will. Another thing to notice about the lumbosacral plexus in relation to the nerves that we've talked about, which would be the femoral nerve and the obturator nerve, the branch which includes the femoral nerve spatially is behind the branch that supplies the obturator nerve. And so we can also refer to this as the posterior division of the lumbar plexus and the anterior division of the lumbar plexus. That's going to supply innervation to the leg. And specifically, when we look at the obturator nerve and the femoral nerve, as far as the dermatome is concerned, the obturator nerve is innervating the medial thigh, and the femoral nerve is innervating the anteromedial thigh as well as the anteromedial lower leg, all the way down to the medial ankle. As far as muscles are concerned, the femoral nerve will supply innervation to all of the muscles in the anterior compartment of the thigh, which will include all of your quadricep muscles, the vastus medialis, vastus lateralis, rectus femoris, and vastus intermedius, as well as branches that will innervate the iliacus and pectineus muscles. The obturator nerve then will innervate all the muscles of the medial compartment of the thigh, so all of your adductors, except for one part of the adductor magnus that's innervated by the sciatic nerve. All right, the lumbosacral trunk is also known as the lower division. So we talked about the upper division, which was a lumbar plexus. Now we have the lumbosacral trunk, which we showed in the pelvic floor lecture. But now we're going to go through what is actually in the lumbosacral trunk and what it innervates. So specifically, we see the lumbosacral trunk right here, and it is made up of contributions from a branch coming off of L4 as well as the entirety of L5. So it's just a short region here that then ends up joining up with the rest of the sacral plexus downward. So the sacral plexus then, highlighted right here, is formed by the lumbosacral trunk from L4 and L5, and then contributions from which then go into the pelvic cavity and then combine with S1, S2, S3, and S4 to form what we know as the sacral plexus. And so a couple things I want to point out before we go any further with this. Notice that the sacral plexus is divided into our dorsal divisions and ventral divisions. What that means is that spatially, the ventral divisions in pink here are in front, and the dorsal divisions are in back. So if you're looking at somebody standing in anatomical position and you see their nerves, the ventral divisions are going to be first, or when you're doing the dissection, and the dorsal divisions are going to be behind that. So this is just how they're organized spatially. And when we mention ventral or anterior rami, and we'll talk about this when we get to the spinal cord, that just means that they are branches coming out of the spinal nerves that innervate either the anterior and lateral parts of the trunk, or so that would be your thoracic and abdominal regions, or limbs. And in this case, this would be innervating limb, and it contains both sensory and motor neurons. So then what does the sacral plexus supply? Well, if you read here, the gluteal region. All right, so your gluteal muscles, posterior thigh, leg, okay, and by leg we mean lower leg, not the upper leg, which we refer to as the thigh, and the foot. So just a brief summary of the muscles that are going to be supplied. The superior gluteal would innervate the gluteus medius and minimus muscles, as well as the tensor fasciae latae. The piriformis muscle would obviously go to the piriformis muscle. The sciatic nerve will cover in the next slide, because obviously the sciatic nerve is enormous. In fact, we talked about that. It's the largest nerve in the body, so it's going to go to a lot of places. And then you have branches from the ventral division that's going quadratus femoris, inferior gemellus muscles, and we'll show where those muscles are later on. Obturator internus, superior gemellus, posterior femoral cutaneous nerve, so that would go to the skin of the posterior portion of the leg, as well as the pudendal nerve. And we talked about in the pelvic floor lecture about what the pudendal nerve goes to. Looking specifically at the sciatic nerve, notice that it has also divided. It's divided into a dorsal division and a ventral division. All right, the dorsal division we see here in orange, and the ventral division we see here in pink. And that doesn't mean that it's going to the dorsal portion of the leg and the ventral portion of the leg. Again, this is just spatially where this nerve, uh, how this nerve is divided within its where it's sitting. Or, in other words, that's how it's anatomically divided. We can also divide it functionally. So, the dorsal division we can also refer to as the common fibular part, and that right there tells you that it's going to go down the lateral portion of the leg, whereas the uh, pink here, the ventral division, is also known as the tibial part. So that's going to tell you it's going to go down the posterior medial part of the leg. And there's some variation in this nerve because it's going to split into the tibial nerve and the common fibular nerve. Sometimes that split happens right away as soon as it's exiting the pelvic region. Sometimes that split doesn't occur until later on, almost right before it hits the popliteal region. All right, so notice that it's going down the posterior aspect of the thigh. And then most commonly, it splits down here near the popliteal region into the tibial nerve. And you notice that's going right along the tibia here, and the common fibular nerve, which is going to branch off laterally and go down the fibula. And there are many branch points coming off of the sciatic nerve, including where it splits off into the tibial nerve and common fibular nerve. So, what the sciatic nerve actually innervates are all muscles in the posterior compartment of the thigh. So, definitely your hamstrings, the part of the adductor, ADD, ductor magnus, that participates in extension of the thigh and is often considered part of the hamstrings, whereas the adductor part of the thigh is part of the adductors and is innervated by the obturator nerve. The sciatic nerve will also innervate all the muscles in the leg and the foot, and the skin on the lateral side of the leg and the lateral side of the foot, as well as the sole of the foot. So this picture is just showing you the dermatome, or the dermatomes supplied by the lumbosacral plexus. And they're not organized by the actual nerves that innervate those regions, but they're organized according to the spinal nerves that they come from. All right, so if you notice, the L1 region is the lateral portion of the hip all the way to the medial portion. L2, L3, L4 medial leg, L5 lateral leg, S1 lateral foot and ankle, L5 dorsal foot, the second, third, and fourth digit, and L4 medial leg and foot, and the great toe. All right, and then of course you look over here and you can see where L2 continues, and notice that the contributions from L2 and L3, L4 and L5 are isolated to the anterior, lateral, and medial portions, whereas S1, S2, and S3 are specifically localized to the posterior portion of the leg and thigh, as well as the gluteal region. All right, so why are these important? What do they mean? Just very quickly, let's say somebody's in an automobile accident and they have an injury to their pelvis, and they say we want to isolate the problem. So what we'll do, and you'll do this specific thing in a lab. So I want to give you kind of the important, or in physical exam lab. So I kind of want to give you the importance ahead of time. So let's say you take a sharp point, and at the other end is a dull point, and you start poking along the leg, and you poke at this region, which would be L3, this region L2, this region L5, this region L4, and the person can feel and discriminate between sharp and dull. But then you start poking along the back of the posterior aspect of the leg, S2, um, and they don't feel sharp and don't feel dull, and definitely can't discriminate between the two. Between the two, but they can do that at S1, then you've effectively isolated the spot of the spinal injury at S2. So that's a way you can isolate where an injury may be originating from, if not peripherally. Okay, so another way we can look at this is regional innervation. Instead of where it's the spinal nerves that they're coming from, the specific nerves that are innervating part of the leg. So if we look at the femoral nerve, this is the area that is being innervated by the femoral nerve. And then your job then is to go back and say, all right, we know the femoral nerve is coming from L2, L3, and L4. And so what this regional map does is it combines all of these from the lumbosacral plexus and puts it into a functional map of, all right, this femoral nerve is going to these areas, and we know it's coming from L2, L3, and L4. Sciatic nerve, notice that an entire posterior portion of the leg. So this is what we call a myotome would look like. So all of the muscles that are innervated, and over here would be the actual dermatome for individual nerves and the skin regions that they innervate. So it's a good idea to start getting familiar with these maps now, so that when you get to physical exam lab, and especially once you get to practice and you're doing some of these things and you notice that you're finding sensory deficits in certain areas, and then you can go back and say, all right, well, if that I know what nerve might be affected, or what specific nerve might be affected, or what spinal nerve might be affected, and then you can better arm yourself with a treatment regimen for that patient.